Hello to all of you. I am Vishnu. So today I am going to talk about my perspective on how to present a case. Now, this actually may vary from person to person's visualization because I have actually presented this case in a very entirely different manner. Some of you may present it in the SOAP format, some of you present in the farm format. Many formats are there. You can do it of your choice. And especially when you present it in front of a professor or a teacher or whoever it is, then definitely they may have their own expectations as in how you present it. So this is something that I made of my visualization. This will give you an idea as to how I approach things practically. And whenever I justify any treatment given to a patient, how do I justify it? So there are a lot of things that I'll come into this. This is going to be a very long presentation. A lot of things will be discussed here. So I would appreciate your patience in the same. And definitely, if you appreciate this video or this effort of mine, then please do subscribe and share it to maximum people. I won't ask you to like because it is boring. But yes, if you like this video, then definitely please do share it to people as well. So let's go. Today's topic is going to be a case presentation on heart failure. This is actually a case that I encountered in my internship. I just made some modifications in the practical knowledge aspects of this, and just I thought that I will share it with you. So when we come to the patient details, it's Mr. X. Usually some people, what they do is they write the name of the patient, and that is wrong because at the end of the day, the confidentiality of the patient has to be maintained. So it is always appreciable not to write the name of the patient. He is a 60-year-old male with a weight of 56 kilograms, and he has a height of approximately 163 centimeter. He was admitted in the cardiology department. He has a BMI of 21.63, which is approximately normal. He was admitted for a period of 5 days. The patient actually had 3 presenting complaints. The patient had breathlessness on exertion for the past 6 weeks. The patient had palpitation, that means increased heart rate. And the patient also had chest pain, which was radiating to the left arm. Now, this is very important. Sometimes some of our elders, what they do is they experience some kind of a heartburn or maybe some kind of a pain in the jaws or maybe some kind of pain in the left arm. And they think that it is because of acidity and they start taking in antacids. They take in either a proton pump inhibitor or an antacid. Temporarily, the heartburn may get suppressed, but that is actually a warning sign of an impending heart attack. Because if you are having any kind of chest pain and it is radiating to your jaws and it is radiating to your left arm, then definitely that indicates a cardiac involvement. You should get yourself admitted in the emergency department as soon as possible, get your ECG checked, and do the necessary treatment. If you look at the past medical history, the patient has a history of hypertension, coronary artery disease, and dyslipidemia. So coronary artery disease actually, if that is usually what happens is this development of atherosclerotic mass in the coronary artery. So as a result of which proper blood supply does not happen and the patient experiences some kind of chest pain and breathlessness. If there is a block in a single coronary artery, it is called a single vessel disease. You can find this kind of technical terms in, echocardiography or ECG readings or something like that. If there are blocks in 2 coronary arteries, it is called double vessel disease. And if there are blocks in all the 3 coronary arteries, it is called triple vessel disease. So the patient has a history of hypertension and the patient was under Ramipril, which is an ACE inhibitor for the past 3 years. The patient also has a history of coronary artery disease for which he was taking aspirin for the past 1.5 years. And the patient had DLP. DLP means dyslipidemia. So for that, the patient was taking atorvastatin for 2 years. If you look at the vitals chart, there was a small variation in the blood pressure. that is on the second day, that is 160/80. Otherwise, it was kind of normal only based on the age of the patient. And the remaining vitals, there were no significant abnormality to be seen. If we look at the blood counts, hemoglobin is very good. TLC is fine. All the other values were kind of normal. There was no specific abnormality to be seen. Yes, FBS, fasting blood sugar, was a bit on the higher side, but then also it is not completely abnormal to be said that the patient is diabetic. If we look at the renal function test, serum creatinine is a bit high. Urea is also a bit on the higher side, but actually the problem with normal values is that when we look at the normal values in many hospitals, they have their own set of ranges. And in the standard textbooks also, they have their own set of ranges. So this actually varies from person to person. But yes, serum creatinine was a bit high, because if you look at the standard book, usually the book that I refer for normal values is Interpretation of Laboratory Data by Mary Lee. That is actually a PharmD author. In that, actually, the normal value of serum creatinine in children is 0.2 to 0.7 milligram per deciliter. And in adults, it is 0.7 to 1.5 milligram per deciliter. So you can refer that if you wish to. If we look at the electrolyte panel, sodium was a bit on the lower side on the first day, then gradually it increased. Potassium kept on varying, actually, because if you look at Mary Lee, the normal value of potassium you will find as 3.5 to 5.5 milliequivalent per liter. So it was a bit on the lower side if you look at the standard of that book. So yes, it was a bit low, but then it gradually improved as the days progressed. If we look at the other investigation, this is very significant. The troponin level was very high. Means if you look at 99 value of troponin means it is too much high, because its normal value actually comes in decimals. And if you look at 99, that means it's way high. And even though on day 5, it actually reduced by 38 of the value, but still it is high. And if we look at the echo findings, the patient had a concentric LVH. LVH is left ventricular hypertrophy, which is very commonly seen with heart failure. And there was significant LV dysfunction. That means left ventricular dysfunction was seen. Actually, in heart failure, we usually see what is the condition of the left ventricle. If the left ventricle is significantly damaged, then the prognosis of heart failure is usually considered to be a bit tough. We can't say completely poor, it depends on many other factors also, but yes, the prognosis is a bit tough. Anyways, there are a lot of anatomical and physiological things associated with that. You can refer your human anatomy and physiology book for that. So if we come to the final diagnosis based on the patient complaints, medical history of the patient, and definitely based on the evaluation that was done, the patient was diagnosed to have acutely decompensated heart failure, severe LV dysfunction, moderate pulmonary artery hypertension, and severe tricuspid regurgitation. There is one thing that I wish to add here is where the cholesterol profile or the lipid profile of the patient was not performed. And that is actually a mistake, considering that the past history of the patient was dyslipidemia and the patient had coronary artery disease as well. Then definitely that should also have been done, which wasn't done. Now let's come to, whenever we study a particular case, you see, I don't know exactly how your hospital duties are going or how you are guided or how you motivate yourself to take cases. But obviously, always remember that whenever a patient comes with a disease in the hospital, and if the patient is having any kind of comorbidities, we always try to connect the dots. Connecting the dots means whether the comorbidities the patient is suffering from has anything to do with the current diagnosis the patient is admitted with. So that is very important. Like, for example, if a patient is having CKD and the comorbidity of the patient is diabetes, then definitely we can link diabetes with CKD, because it is a complication of diabetes which is known as diabetic nephropathy. So like that, we should know. It is not necessary that everywhere you will get that linkage, but wherever it is possible, try to make that linkage if it is scientifically valid. So here we will also try to make that association. The patient had a history of hypertension, the patient had a history of dyslipidemia, and the patient had a history of coronary artery disease. So whether they have anything to do with the current heart failure the patient is suffering from. So let's find it out. So this is actually staging as per the New York Heart Association guideline. This I actually referred a book for that. You can refer Kodak Imble book for this. It's a very good book for case study analysis and study. So here we have the different stages and different risk factors. Based on that, the grading has been given. So if you look at the lowest part of the triangle, there it is written high risk. So there you can find hypertension and coronary artery disease. So which means that these are very, very prominent risk factors for heart failure. And definitely always remember, if a patient is suffering from coronary artery disease, then somewhere or the other, dyslipidemia also has a role to play. Because atherosclerosis happens and then there are a lot of pathological process that takes place, only then coronary artery disease happens. So for atherosclerosis to happen, first cholesterol deposition must take place. So dyslipidemia is also a risk factor that can be correlated with heart failure. So this is just a connection that I thought I will share with you. Now, these are just theoretical aspects. These are some important catch points that you can make out of it. And anyways, if you want this PowerPoint presentation, then you can just contact me, or you can comment in the. You can just contact me at LinkedIn, or you can contact me in my email. Then I'll be very happy to share it with you. So this is exactly what I wanted to tell you, that it is not necessary that you, whenever make a presentation, you should include theoretical aspects also into it, because some people want theoretical aspects into it and some people want that you only present the case, you don't have to say anything about the theory. I just shared some things here because these are some very interesting catch points that I felt that it might be good for your knowledge perspective. I haven't said everything about heart failure here, so I just thought that I'll share something. So, but it's not necessary that you have to do that. But yes, if you want to upgrade your knowledge, you are always welcome to learn more. So, heart failure is a complex clinical syndrome. It's a cardiac condition that results from any structural or functional cardiac impairment of ventricular filling or ejection of blood. So, we usually look at the ejection fraction. Lesser the ejection fraction, poorer the prognosis of heart failure. So all these things are technical terms. You can refer what is ejection fraction, what is the function of the left ventricle, how is it related to heart failure, and all these things. Congestive heart failure is a subset of heart failure which is characterized by left ventricular systolic dysfunction and volume excess. So in this condition, you can experience edema also. Volume excess happens. Why that happens, we'll come into that later. Heart failure is further subdivided into heart failure with reduced left ventricular ejection fraction or heart failure with preserved left ventricular ejection fraction. So we can divide heart failure based on the condition of ejection fraction. So if the left ventricle is damaged, then the ejection fraction will be low. So this kind of heart failure is usually considered to be serious. But if there is a heart failure in which left ventricle is not that significantly damaged, so definitely the ejection fraction will be kind of normal. So that heart failure is usually considered to be easily treatable. Now let's come to some of the drug-induced heart failure, which are the different drugs that can cause heart failure. So negative inotropes, so they usually reduce the contraction property of the heart. And definitely heart failure means any organ failure means the organ is not able to perform its function. That is called organ failure. So we can come to beta blockers. This usually happens with propranolol and non-selective beta blockers. Why non-selective beta blockers is because they block all the three beta receptors, beta 1, beta 2, and beta 3. So beta 1 receptor block means bradycardia. Beta 2 is associated with vasodilation. If you block that, then again vasoconstriction can happen. And beta 3 receptors, if it is blocked, beta 3 receptors are usually found in the adipose tissues. So they actually help in reducing the bad cholesterol and increasing the good cholesterol. So if it is a patient who is suffering from dyslipidemia and you are giving a non-selective beta blocker to such patients, then it can be a matter of concern. There are lesser risk with beta blockers who are having intrinsic sympathomimetic activity. That means they are actually kind of modulators. They are not complete beta blockers. So for example, acebutolol, cartiolol, and pindolol. Timolol eye drops also carry risk, but again, it is an eye drop. How much eye drop will you apply in your eye for it to cause heart failure? So the risk might be there, but it is not that significant. Then we can come to calcium channel blockers. Calcium channel blockers, verapamil has the most negative inotropic and atrioventricular blocking effects. So definitely if it is having atrioventricular blocking effect means it can lead to heart failure. Amlodipine has the least risk of causing heart failure. Definitely antiarrhythmics, they are reducing the rhythm. So definitely that can lead to heart failure. So disopyramide, flecainide, and tronidorone, they may be correlated with heart failure. Then we can come to direct cardiotoxins. Direct cardiotoxins means these molecules directly go to the heart muscle, damage it, and that can lead to cardiomyopathy or heart failure, whatever it is. So cocaine and amphetamines, people who overdose on them, so that can lead to this problem. And it is also associated with long-term myopathy. So if you are having a chronic intake of this kind of abusive substances, then definitely it can damage your heart muscles in the long run. Anthracyclines are usually used in cancers, especially in breast cancer. Anthracyclines are used. So doxorubicin and daunorubicin are usually very culprit agents. They are considered to be culprit agents to cause heart failure, and that is why we use an antidote also. The antidote's name is desrazoxane. So you can refer anti-cancers for that. So it is usually dose-dependent toxicity. And then we have class 2A and class 3 antiarrhythmic drugs. So they can cause QT interval prolongation, which can lead to torsidos D points. So that can actually make the cardiac functioning abnormal. That can lead to direct cardiac arrest or maybe heart failure. Even non-arrhythmic drugs can also do the same thing. But the thing is that maybe, for example, you are taking a particular drug which doesn't cause arrhythmia, but increases the plasma drug concentration of another drug which causes arrhythmia or which causes heart failure, then that can also be a matter of concern. TNF antagonist, TNF is tumor necrosis factor. So there are some case reports in which infliximab and etanercept, these are usually used in Crohn's disease. It's a gastrointestinal problem, and definitely in rheumatoid arthritis they are used. In some conditions, it has been seen that it can cause new onset heart failure, or if a patient is already having heart failure, then it may exacerbate it. So these are just some case reports. So we have to be aware about it. There are some anti-diabetics which can cause heart failure. For example, thiazolidinediones, because they cause sodium and fluid retention. So that can also cause heart failure. Dipeptidyl peptidase 4 inhibitors, which are also known as gliptins. They are also, some of them are implicated in causing heart failures. NSAIDs actually have prostaglandin blocking action and sodium retention, especially if you are using COX-2 inhibitors, then it will be a much more matter of concern, because COX-2 inhibitors are like celecoxib, etoricoxib, etc. They should not be used in patients who are having severe cardiac issues, especially myocardial infarction. Even COX-1 inhibitors have their own problems, but COX-2 inhibitors are much more dangerous. Glucocorticoids, androgens and estrogens, they have mineralocorticoid effect. So definitely you know which is the mineralocorticoid in our body, and that is aldosterone. And aldosterone means it will activate the RAS pathway is activated. So as a result of which aldosterone is formed. And aldosterone will increase sodium, aldosterone will increase fluid. And both of this, and definitely aldosterone has another notorious problem also. It can actually cause cardiac remodeling. So that actually leads to myonecrosis, which can lead to heart failure. Licorice is actually a supplement, which is, considered as a home remedy for many conditions, but they also have aldosterone mimicking effect. And so it can lead to sodium retention, which is a matter of concern. Some antihypertensives can also lead to heart failure, which is very surprising. For example, hydralazine, methyl-dopa, prazosin, and minoxidil. Minoxidil, anyways, is not commonly used as an antihypertensive now. It is usually used in shampoos for hair growth. The reason behind it, of which is they actually reduce the renal blood flow. So that can actually cause activation of RAS, renin, angiotensin, and aldosterone system. So you know what happens after that. The last product is going to be aldosterone, which is a matter of concern. If you are taking any kind of drugs which is high in sodium, which is overloaded with sodium, that can also be a matter of concern, especially in long term. And it's not necessary that it will happen in everyone. If you already have a cardiac issue or if you're already suffering from heart failure, then this can exacerbate the situation or make matters worse for you. So selected IV penicillins or cephalosporins or bicarbonate containing antacids and analgesics. This is just an article which I wanted to show. So this actually we wrote and review article. We just wanted to see the effects of dipeptidyl peptidase inhibitor 4 and what is its role with heart failure. So we found that sitagliptin, like that, some DPP4 inhibitors are there, which can be correlated to heart failure. But again, as I said, that it is always not necessary that all molecules which we have mentioned here, they will definitely cause heart failure. It depends on person to person, how they respond to the medicine, how the body responds to the medicine. And definitely it also depends on individual comorbid conditions or risk factors. So a lot of things need to be taken into consideration. So these are some adaptive mechanisms in heart failure. What happens? This is just like a pathophysiological approach. So there will be a lot of terms here like preload, afterload. A lot of things are there. Sympathetic nervous system overactivity, activation of RAS, antidiuretic hormone, blah blah things. So you can just refer it in your textbooks. I don't need to explain much about this. So you can get it we have like Frank Starling mechanism, like that, lot of mechanisms are there. So you can refer it. If you look at the clinical manifestations of heart failure, so that depends on which kind of ventricular dysfunction you are suffering from. If you are having left ventricular dysfunction, the symptoms will be a bit different. And if you are having right ventricular dysfunction, the symptoms will be a bit different. If you are having left ventricular dysfunction, then you may have dyspnea on exertion. That means you will have breathlessness when you move a bit or do some kind of activity, although it is very mild. You can have shortness of breath, orthopnea, cough, weakness, fatigue, confusion, paroxysmal nocturnal dyspnea. Left ventricular hypertrophy, you will have ejection fraction less than 40%, rails. So a lot of things will be found. Increased bun will also be seen. So in this case also, we actually found that the patient's bun was 33 odd something. So that also clearly explains why the patient's bun was actually increased, because there was poor renal perfusion. In right ventricular dysfunction, we have peripheral edema. We can have weight gain definitely, because you are having edema means fluid retention happens. So you can have weight gain, possible weight gain. Neck vein distension, hepatomegaly, and hepatojugular reflexes. So this is some guideline, just a very simple guideline of the management of heart failure. What do the guidelines say? Just a very small thing. You can just refer it. Anyways, if you want the slides related to this, I will send it to you, because we have to go directly into the case and explain about that. This is also a very good representation into different stages of heart failure activity and which are the different drugs that block it at the different stages. So you can see a lot of drugs here in red color. They are blocking different stages. So nitrates are blocking the preload, or hydrolazine is actually acting on the afterload. Beta blockers are blocking the beta 1 receptors, which actually start from the juxtaglomerular cells of the kidney. Spironolactone blocks the aldosterone. ARBs are having their own action. So different molecules are acting at different areas. So that is summarized here. There are some special molecules for heart failure. Some of these are already in the market. They are used in hospitals as well. We have enamrenone, milrinone, enoximone, and besnarinon. They have inotropic and vasodilatory effects, so that is very good. They block an enzyme known as phosphodiesterase 3, so they increase the cyclic AMP concentration. So that increases the influx of calcium in heart and blood vessels, and that is exactly what we want. When the calcium influx increases, the heart muscles will start contracting because calcium has a contracting property. So that is usually indicated for short-term, severe, and refractory CHF. Refractory means it is not responding to most of the standard medications. Enamrenone can cause thrombocytopenia, so that is why it is substituted by milrinone nowadays. And if at all we have to use enamrenone, so platelet counts need to be monitored. Levosimendan is actually a newer molecule that has also been used in some hospitals now. This actually binds to troponin C, so it increases the sensitization to calcium, and it definitely opens potassium channels, so causes vasodilation. Always remember, potassium is the enemy of sodium. Sodium causes vasoconstriction, potassium causes vasodilation. Then we have NESIRITIDE. So brain-derived natriuretic peptide is something that is secreted by the ventricles. And BNP actually helps to differentiate cardiac from pulmonary causes of dyspnea. So NESIRITIDE is actually a recombinant form of BNP. This also increases cyclic GMP, which helps in vasodilation. It can be used for acute CHF with dyspnea at rest. So for example, you are at rest and still you are having breathlessness issue, then in that condition you can use NESIRITIDE. The problem with this is that there is an enzyme known as neutral endopeptidase that will actually break down this molecule. So the plasma drug concentration will not be achieved sufficiently, as a result of which you will not get the benefits of this molecule. So that is why we can use a combination known as sacubitril. So sacubitril actually blocks this enzyme. So similar example you can remember for another molecule which is known as imipenem cilastatin. It is actually an antibiotic. Imipenem, when it goes into the body, it is broken down by an enzyme known as renal dehydropeptidase. So that is actually secreted by the kidney. So when imipenem is broken down by that, it will not be able to show its antibacterial activity. So that is why we use cilastatin in combination. Cilastatin blocks this renal dehydropeptidase so that imipenem can show its activity. Then we have IVABRADINE, which is a funny current blocker. It is usually used in angina pectoris. So this drug causes bradycardia. Actually, what happens in angina pectoris is that you experience tachycardia. Now, why do you experience tachycardia? It is very simple. The heart is not receiving oxygen. That is what you call angina pectoris. That is the chest pain that you experience. So when the heart is not getting oxygen, it will try to beat more in order to get more blood and nutrients. So that means the myocardial oxygen demand increases. Definitely, if somebody is trying to suffocate you, you will try to, and somebody suddenly releases that suffocation, you will try to gasp and breathe more because the oxygen demand in your body increases. So this drug, what it does is it causes bradycardia, which reduces the myocardial oxygen demand. So as a result of which the angina that you are suffering from will be reduced. So according to European guidelines, IVABRADINE is recommended for patients with heart rate who are having greater than 70 beats per minute. Ejection fraction is less than 35%, which is very poor. and if they are refractory to beta blockers, ACE inhibitors, and aldosterone antagonists. We have vasopeptidase inhibitors, for example, Omapatrilat and sampatrilat. So they actually inhibit the enzymes ACE and neural endopeptidase, as I said before. The major ADR is angioedema. So that is usually seen with ACE inhibitors. It's a very common side effect. The major side effect is angioedema. So that is why we usually use a combination, and this is a very, very famous combination. We use a combination of valsartan and sacubitril. So this is a very famous combination which is used nowadays in patients who are experiencing severe heart failure with reduced ejection fraction. This is actually a molecule under clinical trial. I think still the trial is going on. It is known as alstaroxime. It is an investigational steroid. It was under phase 2 trials currently. I just have to refer once whether I think it has progressed into phase 3 or not. It is almost the same mechanism as digoxin. But the benefits of alstaroxime over digoxin is that it increases the influx of calcium in sarcoplasmic reticulum, which is very good because it increases the contraction property, and it has lesser arrhythmic side effects compared to digoxin. Digoxin actually has arrhythmia related side effects. In alstaroxime, till now, whatever reports we have received, the side effects of arrhythmia, the cardiac conduction side effects, are comparatively found to be low. Now let's go back to the case. So if you look at the treatment provided to the patient has been given furosemide, digoxin, ramipril, nitroglycerin, carvedilol, atorvastatin and clopidogrel combination, pantoprazole and domperidone combination, tolvaptan, potassium chloride in syrup formulation, and heparin. Now, what we are going to do is we are going to justify each and every treatment that has been given to the patient. So this is actually my way of justifying a particular therapy. So for example, what most people do is when they justify a particular molecule, they simply write down the mechanism of action, then they write a lot of side effects, they write morning. I don't exactly understand why do you need to write side effects in a case presentation. If you are writing side effects in a case presentation, it simply signifies that the patient has underwent all the side effects that has been written in the slide. So please write side effects only when the patient has actually experienced it. Otherwise, don't do that. Justification of any molecule in a particular treatment chart means you have to say why this medicine was given to this patient. We are not bothered about the mechanism of action because mechanism of action is a generalized concept. But here you have a patient in front of you, which is an individualized concept. So furosemide has been given to this patient. I just referred some articles. So I found that it is very good for decompensated heart failure. So I just took the screenshot of that article and I pasted here. So this justifies my argument that furosemide is good for a patient who is suffering from heart failure. This is a 1997 New England Journal of Medicine. Anyways, digoxin is a standard therapy for heart failure, so you know that very well. But please remember that digoxin is not a forever therapy for heart failure. Like for example, if you are entering a vehicle, you are using the key to start the vehicle starts. But it doesn't mean that it will automatically take you to the destination. You need the steering wheel, you need the accelerator, the brake, the gear changing, all these things. Only then, if you balance all of these things, only then you can reach your destination. Similarly, digoxin just triggers the heartbeat. It just starts the heartbeat. It does not prolong it. For that, you need other medications to block other pathophysiological mechanisms so that a coordinated effort helps to keep the heart healthy. So digoxin is also a good therapy for heart failure. That is what is written. Then we have ramipril. Ramipril, definitely it's an ACE inhibitor. So ACE inhibitors are very good because they block the production of aldosterone somewhere or the other. And aldosterone is a notorious molecule which can lead to myonecrosis and can worsen heart failure. So ramipril is a good molecule. Then nitroglycerin is also good. Nitroglycerin is good for heart failure because especially if it is associated with, angina or cholesterol related dyslipidemia or something like that. In that condition, nitroglycerin can act as a powerful vasodilator, which can improve the blood flow. So that is good for heart failure. Carvedilol is also good for heart failure. This is also 1996 New England Journal of Medicine article. So here also they have talked about the importance of carvedilol in heart failure. It's a very, very good molecule for heart failure. Then we have atorvastatin. Atorvastatin actually has pleiotropic effect. Anyways, in this patient, atorvastatin has been given because the patient already had a dyslipidemia and coronary artery disease related problem, and that can lead to heart failure. And atorvastatin actually has anti-inflammatory effect as well. So that improves the function of the endothelium, vascular endothelium. So that is also good for heart failure indirectly. Tolvaptan is also very good for heart failure because it is a vasopressin receptor blocker. So that is actually good for reducing edema related problems or something related to heart failure. If we look at the progress report, see, this is also very important. What we do is we don't know. Like for one day, we took the case of the patient. After that, what happened to the patient, we don't know. So we should always follow up the patient. This is a very, very, I don't understand why this practice happens in many colleges. Like people are forced to take a lot of cases in a month. It is simply a, formality kind of situation because if you are taking a lot of cases in a month, you will not be able to follow up all these cases simultaneously. So it is good to take selected cases in a month, but to treat them with dedication, to follow them up with dedication. Even if you're taking 5 cases a month also, that is more than enough. But you should be knowing A to Z of that 5 cases. And that is what actually makes a good practical skill out of it. So progress report analysis is important. The patient was admitted on the first day with significant complaints. The chest discomfort was very high and the patient was hypokalemic. Palpitations were there and troponin was high. On the second day, the hypokalemia was still there. Troponin actually a bit reduced, but it was still significant. Manifestation started reducing a bit. Potassium levels normalized. Troponin reduced in the third day, but again it was still significant. There were no fresh complaints. There were no fresh complaints on the fourth day as well. Troponin reduced, but it was still significant. And the same thing on the fifth day also, the troponin was 61. It was less compared to the 99 on the first day, but it is still significant. The patient had no fresh complaints and the patient got discharged. So if you look at the discharge summary, a 60-year-old male patient who had a compliance of hypertension, dyslipidemia, and coronary artery disease presented with breathlessness and chest pain. The troponin one was highly significant. On the first day, it was 99. On the last day, it was 61. Although it was 61, still it is significant. The patient was diagnosed as acutely decompensated congestive heart failure with significant left ventricular dysfunction. The patient was treated with diuretics, digoxin, ACE inhibitors, and other supportive measures and was discharged in clinically stable condition. If we look at the discharge medications, Lasix was given, which is furosemide. GTN sorbitrate is nitroglycerin. Cardivas is carvedilol. Astrolate is atorvastatin clopidogrel combination. Natrice is tolvaptan. Lanoxin is digoxin. Ramistar is ramipril. Pan is pantoprazole. And syrup potchlor was actually given. Actually, I forgot to tell you why potchlor was given. Because the patient was actually suffering from hypokalemia. So as I said, on the first 3 days, the patient was having low potassium levels. So syrup pot chlor was given. It was actually not so significantly low that we had to give it through IV route. If it was very significantly low, then potassium chloride is available in IV form also, which is a high risk medication. But here it was 3.3, 3.2, something odd like that. So with syrup pot chlor itself, it got normalized. And the patient was asked to review after 2 weeks in cardiology OPD. Let's come to pharmacist observations. So if we come to the drug interactions, this is another thing which I very commonly see with people. They simply write drug interactions, but they don't know whether actually that interaction happened in the patient or not, or whether it is practically possible or not. Whenever you document drug interactions, please make sure that you see whether both the medications were given at the same time or not. Lot of things you need to take into consideration before saying that there is a risk of a drug interaction or a drug interaction has happened. So here, whatever drug interactions I saw, because they were given at the same time, those I have noted down. And if you want to know, simply write drug interactions in the case, but it has actually not happened in the patient or there were no such risks, then please write in the bracket theoretically. Theoretically means this is just for knowledge purpose. So atorvastatin plus digoxin, if it is given, it is a major interaction. So it actually increases the plasma drug concentration of digoxin. So definitely you know very well, digoxin is a molecule which requires therapeutic drug monitoring. Carvedilol, if it is given with digoxin, so digoxin is having most of the interactions here. Carvedilol, if it is given with digoxin, it is like pharmacodynamic synergism, both show the same effect. So there is a high risk of complete heart block. That is also another problem. Clopidogrel, if it is given with heparin, so that can cause like pharmacodynamic synergism. There is a risk of bleeding because one is an anticoagulant and the other is an antiplatelet. Both cause bleeding as a side effect. Tolvaptan plus digoxin, if it is given, that also increases the plasma drug concentration of digoxin. So that can increase or exacerbate the side effects of digoxin. Digoxin, if it is given with furosemide, that can increase the loss of potassium. So that can precipitate hypokalemia. So that can also again increase the risk of digoxin toxicity. Potassium needs to be monitored. Let's come to the drug-related counseling tips. So furosemide, there is a potent risk of hypokalemia. So good intake of potassium supplements is required. You should avoid activities requiring mental alertness and coordination because it causes dizziness. Very simple, because this causes dehydration. It's a very powerful diuretic. And also for elderly patients and even adults also, normal age also, if you are taking diuretics, you should always, if you are living in a tropical area, or if your body is of such a kind that you sweat a lot, then please make sure that you carry sources of juice or water bottle with you, because it can cause dehydration. And if you are already having a sweating capacity, you sweat a lot, or if you are going under the sun, there may be a risk of heat stroke. So that is why if you are under long-term diuretic therapy, please make sure that you carry water sources with you so that you can sip water in between and not experience this drastic effects. GTN sorbitrate, it causes, it is nitroglycerin. It can cause severe hypotension because it's a very powerful vasodilator thanks to the nitric oxide molecule that it releases. Please avoid activities requiring mental alertness and coordination because it can cause dizziness. Because it causes obviously vasodilation, so it is understood. And it can also lead to headache also. Always remember, vasodilators can lead to headache as well. Carvedilol is also the same thing. You should avoid activities requiring mental alertness. It can cause dizziness. So if you are having, severe hypotension also, stop the medicine and then consult the physician or the pharmacist. You should take it with food, so it improves the absorption of the molecule. And definitely for every medicines, we usually say avoid sudden drug discontinuation. When it comes to ramipril, please avoid activities requiring mental alertness and coordination because it may cause dizziness. If you're taking this medicine, rise slowly from a sitting or lying position. That we usually advise for other antihypertensives also, whether it is telmisartan or something like that. For that also we usually say, especially if it is a geriatric or somebody who is taking the medicine for the first time. If you are having any symptoms of angioedema, please stop the medicine immediately and consult a physician or a pharmacist. So the symptoms can be deep swelling around the eyes and lips. So the doctor will stop that medicine and he will start an angiotensin receptor blocker. You can maintain sufficient hydration to prevent volume depletion and subsequent hypotension. Digoxin, okay, it is actually a drug that requires, therapeutic drug monitoring. So you can report the symptoms of drug toxicity. For example, anorexia, nausea, vomiting, vision disturbance. Actually, it can cause some kind of color blindness also, halo-like color blindness. So if you are experiencing all those halo effect and all, you can report to the physician or the pharmacist. Atorvastatin and clopidogrel, this is actually, I don't really understand why it happens. If you refer Kodak Imlay and some very standard textbooks, you can find it out that statins can be taken at any time of the day, especially 3 statins. One is pitavastatin, one is atorvastatin, and the other is rosuvastatin. Usually physicians, what they do that, they write it at night time, but it is not so. Atorvastatin, the half-life is 14 hours. Pitavastatin, the half-life is 12 hours. It is actually the most potent statin also. Please remember that. Pitavastatin is the most potent statin. And rosuvastatin has a half-life of 19 hours. So definitely you can take it any time of the day, but please make sure that you take it at a fixed time every day. Why this theory comes that statin should be taken at night time is because it is believed that cholesterol biosynthesis happens the maximum at midnight and the least at midday. So on that basis, usually physicians write it at night time, but atorvastatin, rosuvastatin, and pitavastatin can be taken at any time of the day. If you are experiencing symptoms of myopathy, usually happens due to statins. So you can have, rhabdomyolysis kind of condition. So if you are having muscle pain, tenderness or weakness or any kind of fever which is unexplained, then you can report those to the physician or pharmacist. If you are having any symptoms of liver injury, because it can raise your liver enzymes like dark urine or upper abdominal discomfort, you can refer to the physician or the pharmacist. Pantoprazole, you can take at least 30 to 45 minutes before or 2 hours after food. It can cause non-resolving diarrhea. Now, why this happens, please refer to my video on how to remember drug side effects. There I have explained the example of proton pump inhibitors, why they cause diarrhea. You can refer there. It can cause diarrhea and constipation as well. There are a lot of mechanisms behind. And definitely if it causes hypomagnesemia, so if you are having dizziness, palpitations, insomnia, all this kind of things, or lack of energy and vitality, then also you can report. Tolvaptan can actually cause osmotic demyelination syndrome. It's not very common, but it may happen in some. So the symptoms are dysarthria, mutism, very much of fatigue, tiredness, lethargy, dysphagia, difficulty in talking, and spastic quadriparesis. So if you are having this kind of symptoms, please do report. If you are having manifestations of liver injury, like you are having abdominal pain or diarrhea or yellowish discoloration of the skin, sclera or urine, then you can report. You should maintain adequate hydration to prevent the risk of dehydration and hypovolemia. Disease-related counseling tips, stress reduction. Actually, I've seen this in many PPTs and slides. People say to avoid stress. I personally believe that stress is not a button that you press it and it instantly goes away. We can say stress reduction. So psychosocial counseling, if the patient is heavily stressful, or emotional support and all these things can be helpful. Sedentary lifestyle should be avoided. Keep as much as possible, keep your body engaged. as much as possible. If you experience any of the following symptoms in future, do consult the nearest healthcare center as soon as possible. If you are having chest pain that is radiating to the jaws and the back, if you are having shortness of breath, if you are having palpitations or severe dizziness, please make sure that you don't neglect it. You refer to the nearest healthcare center. Some lifestyle related counseling tips for hypertension. It is lemon juice. Lemon juice is a very powerful vasodilator, and definitely if you're taking it with honey or a little bit of sugar, then definitely it's a very good drink also, especially in the summer seasons. So you can take it on an empty stomach. It's excellent. Cucurbitacin, it is also a very powerful vasodilator. So this also is very good for reducing your blood pressure. So that is good. Garlic is also good. It's a very powerful vasodilator. There are garlic supplements that are available. So you can take that. But I don't personally prefer people to take supplements because it is very concentrated. And if you are taking it with an antihypertensive, then you can have additive hypotension. So I personally believe that if you want to take garlic or you want to enjoy the benefits of garlic, you take it through food or you chew a piece of raw garlic. I know that it smells very bad. So you can take a little bit of honey after that. But I think that is the best thing that you can. And definitely coconut water is excellent. It is rich in potassium, which is a very powerful vasodilator. Magnesium is excellent, and vitamin C. So it is highly antioxidant in nature as well. So that helps to reduce your systolic blood pressure. So if you are suffering from extremely high systolic blood pressure issues, you can take proper coconut water on a daily basis. That can be useful. Honey is also good. It's a very powerful antioxidant. It has a lot of other benefits, but it is good for reducing your blood pressure. And fenugreek seeds are also good. It has an artistic taste also. You can just put it in water or make it a bit lukewarm and then consume it. It's excellent. For coronary artery disease, you can take all these foods. We have olive oil, we have garlic, pomegranate, avocados, almonds, broccoli, turmeric, asparagus. Asparagus is a bit costly. Salmon is actually a fatty fish. Fatty fish, it is rich in omega-3 fatty acids, which is good for the heart. And definitely watermelon. Watermelon is excellent. So this actually helps in cleansing your arteries. So that is also good. These are some tips to prevent heart disease worsening in general. Garlic is good. There is a supplement called Hawthorne, but this is actually an international supplement or something, so you don't need to worry much. There are so many things that are available in our country. We can try that itself. But Hawthorne actually improves the cardiac performance. It reduces the cardiac workload. It relaxes the heart. And it also has an anti-arrhythmic effect, which helps in regulating the cardiac conduction system. When we have Arjuna, which is a Ayurvedic supplement, we have a cane papers, we have turmeric and green tea. Green tea is excellent. I always tell that green tea, although the taste is not that good, but please don't take green tea with sugar. If you're taking green tea with sugar, then you don't get any benefits ever. You take it green tea with honey or maybe stevia, which is a natural, sweetening agent. So that is good. And if you are adding good amount of sleep, please avoid sleep avoidance, insomnia. That is very bad for the brain and definitely very bad for the heart. If you have a balanced diet, you avoid saturated fats as much as possible. And if you have sufficient exercise, I don't ask you to take intensive exercise because again that puts pressure on the heart. Don't do intensive exercise. That is very bad. You can suddenly develop a cardiac arrest. Do moderate exercises. If you are feeling that you are having too much of palpitation, stop the exercise, sit somewhere and relax. And definitely stress reduction also is important. So if you do all these things, then definitely it will be good to prevent the worsening of your heart. So I hope that you don't have any queries, but if you do have queries, then please post in the comment section. And you can contact me also. My email ID you have. You can contact me at LinkedIn. My name is Vishnu R. Nair there. You can contact me there if you have any queries. You are always welcome. If I know the answer to that, I'll definitely respond to you. But if I don't know the answer to that, I'll definitely refer and I'll try to revert you back as soon as possible. So that's it. Thank you so much for listening to this long presentation. It has been really long. This is just my idea as to how to present a case. I hope you have got my idea. I'll come with another model in the near future. That is also another way how I presented a case during my clerkship exam. So that will also give you another idea. So I hope I have been of service to you with regards to practical knowledge. And if you like this video, then definitely share and subscribe. Until then, it's goodbye.